In the last 10 years, there are 1,737 papers on post-prostatectomy incontinence, and I don't have a resident or fellow, and yeah, I counted them all. There are 122 papers that deal with dissection and reconstructive techniques to improve continence. And guess what? There's 122 papers that also discuss dissection and reconstructive techniques at the apex. But in those same 10 years, there were 400 papers that looked at MRI to evaluate the pelvic anatomy. This is interesting because MRI actually allows you to see changes in anatomic relationships for stuff that you didn't touch. And then you can track these things serially post-operatively to see how they change as the patient recovers. What do we see here? We see a consensus amongst these MRI papers. 400 papers all saying the exact same thing. They say that when we do pelvic surgery, there is a neuromuscular injury to the levator. And when you injure that, you get a lengthening of the levator complex. So the muscles, because they're not as tense anymore, relax. There's less innervation, or you've traumatized them. They relax, your levator complex lengthens. As the levator complex lengthens, incontinence increases. As continence improves, guess what you see on MRI? You see a shortening of the levator complex. How can we improve our ability to avoid muscular trauma and pudendal nerve injury? Because clearly, this is the culprit. The problem with nerve sparing is we really don't spare nerves. What we spare is the tissue located where we believe the nerves to be. We know that anatomic landmarks are not accurate in telling us where the nerves are. We know that the perineal branch of the pudendal nerve plays an important role in continence, and we know that selective preservation of this nerve actually improves continence. We know that myelinated nerves conduct at about 18 meters per second. We know that if you deliver a specific signal to them, they're going to transmit at a certain rate. And if you measure a tissue's ability to conduct or not conduct, and have a computer program that filters out the noise, you can tell if what you touch is nerve or not nerve. You can instantly know what you're touching. This is actually standard of care in 3 surgical specialties, nerve mapping. If you don't do this, you're actually liable in other surgeries. We should be looking at this. And there are companies that are doing it. They're looking at what's called the compound motor action potential. This is what happens when you stimulate a myelinated nerve that's going to a skeletal muscle. So how does this work? Well, you end up with a laptop computer that's fitted with a program. It delivers a signal through an output channel. That's called the talking part of it in my lack of technology brain. That signal is then transmitted through something. For robotics, we've been transmitting it through the bipolar instrument. And then you've got these probes sitting at the other end that listen. They essentially just listen to what's going on. They listen to the talking, the noise, and they send the information back to the laptop, which then, based on the computer program, interprets what it hears, and based on what we know about spinal surgery and neurosurgery and facial surgery, it can tell you if what you're touching is a myelinated nerve or not. So, if we can play this. We actually looked at this, and I've spent the last 3 years of my life looking at this stuff, and there's a number of companies that are out there that are investigating this. One of the companies I work with. And we looked at, can we affect early urinary control recovery in the hands of somebody like me that does a lot of these? We know that these nerves are not visible to the surgeon. We know that they need to be preserved to improve functional outcomes during surgery. But we also know that the position, the location of these are not reliable. So we also know where they should be. We know that the levator complex is infiltrated, is innervated by the perineal branch of the pudendal nerve. We know where it is. We know where it's supposed to be, at least. And we know how it kind of fans out like a palm leaf as it tracks down next to the neurovascular bundle and kind of fans up to innervate the levator and fans out to innervate the remainder of the pelvic floor, because the pelvic floor truly is one giant layer of musculature, not just this little area around the sphincter. We know we haven't been able to reliably visualize this nerve. We can't see it all the time. And we know that to preserve it, we've relied on our intuition, on our experience. That's why folks who do thousands of these get more consistent outcomes than folks who do hundreds of these, because it's judgment. So the neurodiagnostic tools that were traditionally used for spine surgery, neurosurgery, facial surgery were modified. And some probes were modified. So both the program as well as the introducer was modified in an effort to be able to deliver this same technology to a different set of nerves in a different part of the body. So what are we looking at here? Well, we're looking at the pelvis after the prostate's out. Now this is actually done prospectively. So this is done while the operation is going on. We've got 2 probes that we've stuck through the anterior abdominal wall and put those down into the levator complex. And as we operate, we deliver a signal through the bipolar instrument. Now because we're supposed to be doing an athermal nerve sparing, we shouldn't be delivering any heat through it, so we deliver the signal through it, a small milliamp signal. And that milliamp signal gets delivered and gets sent through the tissue, and those probes on the other end listen, send the information back to the computer. While the prostate is there, we actually can look at the computer and see the compound motor action potential. Now, I don't have a fancy Da Vinci S or SI, I've just got a standard, so I can actually look at the TV screen. But if you have an S or an SI, you just tile probe that right in and look at it while you're going. So while you're operating, you can figure out where these nerves are. And what was remarkable to me in doing this was seeing how important this nerve is and how localized it is. When you touch this nerve, the entire ipsilateral part of the pelvic floor contracts. And when you're a millimeter off, it's gone. So this sort of technology, whether it's through the company that I've been spending time with or through other companies, is one more way that technology is going to continue to improve the way surgeons, our ability to do a good operation. Does this device improve outcomes? No, I don't think any device improves outcomes. What the device does is it provides information. Because what we need as a surgeon is information. We've been pulled 6 feet off the patient. We don't have our hands in there. We've lost our tactile feedback. We don't even have proprioception. We have no haptic feedback. We are starving for information. We need technologies that improve our access to information. Because with that information, we then have the opportunity to improve our outcomes. Thank you very much.